Thank you very much. My sincere thanks to the organising committee for the invitation to participate in this inaugural conference of the aged care for the Agency for Care Effectiveness. It's been a wonderful start to the conference, and I look forward to the presentations this afternoon and this morning. I acknowledge the other speakers, presenters, and distinguished guests, and also colleagues in the audience. We heard yesterday about up-and-coming technologies and the implications for payers, regulators, clinicians, and patients. I added theranostics to my lexicon yesterday and discovered that there was a bi-weekly peer-reviewed journal in my search to learn more about theranostics. So following on from the presentation so far, I will now focus on how do we support healthcare professionals to really undertake and use their clinical skills and support them in their clinical decision-making to enhance outcomes for their patients and minimise harms. Given all of this information, new technologies, how will that translate into best practice, and how can we support the healthcare professionals? Because as we've heard and aware that health systems around the world are really changing to address the challenges to provide timely, value-based care, not only now but into the future. And it's changing rapidly. The pipeline of new medicines and new technologies. The diagnostic tests that are increasing, but also the complexity of illness, multi-morbidity, is the norm rather than the exception. And the number of healthcare carers and organisations make healthcare the archetypical complex adaptive system. And it's not only the therapeutics and the technologies that are part of that complex system, but it's the landscape in which we practice. It can be in primary care, in hospitals. The payers are different. In Australia, we have funding at the national level, but also at the state level. So there's the complexity of the landscape in which healthcare professionals practice and care for their patients. Australia's health, just a brief snapshot, you can see here that 67% of the adult population in Australia are overweight. Dementia, coronary artery disease are still key conditions that contribute to shortening of the life expectancy and add to symptom burden and the multi-morbidity that the citizens of our country face. But right in the centre of that is the increasing mental health problems and mental health issues. So who works in our healthcare system? We have a large number of nurses and midwives, but also our doctors work in both primary and secondary care, in tertiary, and also a large number of allied health practitioners, which includes pharmacists, OTs, physios, and like many health systems, and as recognised in the WHO around the world in terms of workforce, we've got many shortages in Australia in our workforce, and also perhaps a maldistribution of that workforce across our metropolitan, regional and remote areas. But it's not only that the landscape is changing, the technologies is changing, but we've seen such rapid change in the last 2.5 years and accelerated the enhanced use of digital technologies, not only what we as health professionals are using, but what our patients are using. And this has led to also a focus at a global level, looking at we talk often about digital health, and many countries have developed digital health strategies. Perhaps in the future, we won't be referring to it as digital healthcare, but it'll be just part of healthcare. And so all of these strategies impact how we might be able to support our healthcare workforce. And in terms of this report in the United Kingdom, which was around preparing the healthcare workforce to deliver this digital future. And just a really brief snapshot from that report highlights, for example, at the top of that graphic, that telemedicine will be very commonly used. Now, this report was released prior to the pandemic, and we've seen how rapidly we changed to the delivery of telehealthcare, telepractice. And how do we prepare our healthcare professionals to adapt to that new and emerging landscape in which they would be working? So today's reality for healthcare professionals is juggling a whole range of new technologies, new landscapes, and new technologies, but also a very informed community who are also using different technologies. So this quote, whilst a little bit old, still resonates with me, that there's so much information everywhere, and we've really been privileged to be listening to some of that at this conference. But we know how much information there is, but the skill is being able to judge what is important. So in preparing for this presentation, I was looking back and came across this article from 1954. And interestingly, it also highlighted at that time that one of the challenges that they were facing as medical practitioners then was how to deal with the ever-increasing amount of literature, journal articles that they had to keep up with. And the author of this abstract suggested that they might be able to do that by continuing to read all of the journal articles. So that's a long time ago. So now, keeping up with the evidence, this paper that was published in the Lancet, comment actually that was published in the Lancet, was highlighting that if a physician working on a ward round in a teaching hospital in the United Kingdom, that if they had to try and read all of the current guidance for all of the conditions that they would see on that round, it would take them about 122 hours of reading to keep abreast of those guidelines. So this paper, published in the BMJ, I think it really highlights, and it's still relevant today, is that what these authors highlighted is that all of that information, all of that available evidence, that still clinicians, they rely collectively on reinforced, internalised, tacit guidelines that are often informed by brief reading, but mainly by their own and their colleagues' experience, and then interaction with each other and with opinion leaders. So I think it's really important when we think about, in this complex landscape in which we as health professionals are working, how do we support those health professionals, acknowledging how people learn from and with each other. And then we had COVID, and there was even more information that became available. I think we're, in the last couple of years, passing about 220,000 papers on COVID alone. So there was sort of avalanche of new information. So when we think about evidence-based medicine, we're really thinking about the best available evidence, and there's a lot of emerging evidence that we've got available to us. But how do we incorporate that expertise, skills and judgment, but also, as we'll hear in subsequent presentations this morning, also the patient's needs, their values and their preferences, which we also have to weigh. So how can healthcare professionals be supported? So we've heard a lot about the evidence to get a technology or a medicine to market, the evaluation, the critical appraisal that goes into that. And research is continually producing those new findings, but simply identifying that problem or generating that new evidence is rarely sufficient to successfully and consistently change practice. So this has led to an interest in implementation research, because we've spent a lot of our resource in finding those medicines that are most effective. But we also need to consider, well, what are the most effective ways in which we can implement or translate that evidence into practice? And there's a wide range of implementation strategies that have emerged to promote the uptake of research findings and other evidence-based practices. But even with the research that's being undertaken, there's still significant way to go in terms of working out which are the most likely to translate consistently for improving the quality of patient care. Some of you will be familiar that there's the Cochrane Review Group. They have categorised some of the implementation strategies, and I just wanted to focus on the implementation strategies in particular. And some of the examples that are available to us are audit and feedback, communities of practice, educational materials, educational meetings like we're participating in now, and then also educational outreach or academic detailing, clinical practice guidelines, and also interprofessional education. And I would just like to also just highlight this taxonomy of professional practice change and look at the evidence base for those with the most consistent findings for successful translation into practice. So academic detailing, audit and feedback, reminders and recall, and interactive educational meetings have, in some of the systematic reviews that have been undertaken, the most likely to have the consistent findings of successful translation. It doesn't mean that the others aren't effective, and certainly patient-mediated interventions are very important, as we need to work with our communities and certainly develop strategies to support them in their decision-making and work with them, because they also influence the uptake by health professionals. So how might we design or look at what some of the issues are if we are to support healthcare professionals? So these are some of the questions we might ask ourselves. We might look at, is there a drug utilisation issue? What might capture the attention of the health professionals? Is it about new treatment? Is it about repurposing of an old medicine? Is it new knowledge? All of these things are important if we are to support those health professionals, translate that evidence into practice for their patients. They're often not just one intervention. It might involve a multifaceted approach that includes a range of ways in which we can support those health professionals. And this is just one of the examples where it can bring that information together in a portal that can be accessed by health professionals. And this is something that we've learned from the New Zealanders who implemented the health pathways, and we've borrowed that approach in Australia, where it brings together the best available clinical evidence and clinical guidelines, but also some of those other practical things, like that first slide that I had with regards to the landscape, so that those health professionals can find and access other resources, but also making available the current best available guideline evidence. And certainly we saw this in the COVID, and I know here in Singapore, as we've seen, you've got that access. For us, we were using the living guidelines, which really supported the information and made that information available in a timely way so that clinicians could access, be supported. The evidence base in COVID was rapidly changing. It was evolving across time. So it was really important to be able to support those clinicians in that way. Educational visiting and the implementation in Australia the service that I'm the director of, which is the Drug and Therapeutics Information Service, which is based at a teaching hospital in one of our local health networks. We commenced in 1991. In 1999, MPS Medicine Wise began a national educational visiting program. Greater than 70% of GPs in Australia participate in this program, and we've conducted over 500,000 visits across Australia. And around 25,000 health professionals participate each year. Also, this technique is used in hospitals and in residential aged care to support nurses, personal care workers, general practitioners and pharmacists. So this approach, educational visiting, from the landmark paper that was published in 1983, and in 1983, they were just, at that point in time, signing the international agreements for an internet. So even though times have changed a lot since that paper was published, this technique is still very widely used, and it has been implemented in Singapore, and looking forward to the work that has been occurring, and the first program has been delivered here. It's also known as prescriber support and educational outreach. And the objective is educational content that's based on the best available evidence related commonly to prescribing or utilisation of health resources and services. It can be used for program implementation in a range of healthcare settings. It is an evidence-based approach, and as I showed you in that earlier slide, it's in the top 4 of the implementation strategies that has the evidence for consistently being successful in supporting healthcare professionals. And I think one of the reasons why it is a successful technique is because in this landscape of so much information, it can be tailored to the individual needs of the doctor or other health professional that is being visited. These are some of the examples of the therapeutic programs that have been delivered in Australia. So how can healthcare professionals be supported? It is about bringing the best available evidence, really making it accessible at the point of care, but also in reflective practice, in communities of practice. The implementation approaches should be informed by theory and evidence, just like the medicines and technologies that we're using, tailored to the person, their level of knowledge, interest and responsibility, such as is the case with educational visiting or academic detailing. It involves understanding existing behaviour and the key motivations for that individual clinician. It should embrace complexity. We need to, in this digital landscape in which we're working, recognise both the synchronous and asynchronous ways in which we can support. But we shouldn't lose sight of the connectedness, face-to-face, and learning as a social experience. Digital enablement and face-to-face is still important. Interprofessional practice, how will we work in teams? Because it's not only the individual competence that we need to be supporting, but also the collective competence as we work in teams to provide the best healthcare for our citizens of our countries and those we serve. So thank you very much.